Hello again. This presentation is about consistency, also known as coherence, and it's another key principle in network meta-analysis, and it can be understood as the statistical manifestation of transitivity. So let's think about how we assess transitivity statistically. As I've said, the statistical manifestation of transitivity is known as consistency or sometimes as coherence to distinguish it from the grade inconsistency domain. I'm going to use the term consistency throughout the rest of this presentation. Statistical tests can be carried out to assess whether the direct evidence comparing interventions is similar to the indirect evidence. You can express this mathematically with the equation shown. In other words, we get the same true effect estimate when we directly compare B and C, the first half of the equation, as when we'd indirectly compare B and C via comparisons with intervention A. We can measure the amount of inconsistency in a network using a loop-specific approach. This network is from a review examining heavy menstrual bleeding. This network plot shows studies comparing 7 different interventions for second-line treatment, and the outcome being measured is patient satisfaction. There are 27 studies in this network. Let's look at one loop. So, this loop includes direct and indirect comparisons between 3 interventions: resectoscopic endometrial ablation, or REA, progesterone-releasing intrauterine systems, LNG-IUS, and hysterectomy. To recap Emma's presentation, in this plot, the thickness of the lines connecting the interventions reflects the number of the studies making a direct comparison between the interventions. In this case, there are 2 studies comparing REA and LNG-IUS, 1 study comparing REA and hysterectomy, and 1 more comparing LNG-IUS and hysterectomy. The size of the nodes represents the number of studies comparing this intervention to any other intervention in the network. So there are more studies comparing REA to any other intervention than there are comparing LNG-IUS to any other intervention, and also more studies comparing LNG-IUS to any other intervention than there are comparing hysterectomy to any other intervention. So here are the studies that are included in this loop. Firstly, Cosignani 1997 compared LNG-IUS to REA. Secondly, Ergen 2012 also compared LNG-IUS to REA. Thirdly, O'Connor 1997 compared REA to hysterectomy. And lastly, Heiskanen 2004 compared LNG-IUS to hysterectomy. So, let's consider the type of variables that could act as effect modifiers. The authors don't say which effect modifiers they considered, but there are a few that could be important, such as the age of the women, their diagnosis, whether they were happy to undergo radical treatment, the date the study was carried out, and the risk of bias of studies in the network. So, the first step to assess consistency is by looking at the effect modifiers. Are these studies jointly randomizable? Let's look at some key similarities. The ages of the women in the studies varied, but they were all premenopausal. All the women had completed their families or did not have a desire to preserve their fertility. All had a diagnosis of heavy menstrual bleeding, or menorrhagia. The variation in study dates is interesting. Studies were published between 1997 and 2012. However, we assume that the review authors decided that the interventions would have been similar enough. This is the risk of bias graph for studies included in the whole network. As you can see, they appear to be relatively similar in terms of risk of bias. Nearly all were at high risk of bias for blinding of patients, clinical staff, and outcome assessors. That's the performance and detection bias domain, with nearly all the studies being at low or unclear risk of bias for other domains. Let's look at how to assess consistently statistically in this loop. Broadly speaking, there are two approaches, classed as local and global approaches, and it is recommended to use both. The loop-specific approach, which is a local approach, calculates an inconsistency factor, or IF, for each loop by comparing the direct estimate with the indirect estimate within that loop to see if the two estimates are similar. In the Cochrane Handbook, the SIDE approach is recommended as a local approach. SIDE stands for Separating Indirect from Direct Evidence. It is also known as node splitting. This approach calculates the difference between the direct and the indirect estimate for each pairwise comparison to see if these two estimates are similar. This difference is also called the inconsistency factor. In the SIDE approach, the indirect estimate is derived from the entire network when the direct comparison is removed. This process is repeated for all comparisons where both direct and indirect evidence are available. Let's look at the comparison of REA with LNG-IUS. That's the bottom row of the table. As you can see from the network diagram, this was one of the comparisons in the loop that we looked at earlier. The authors have calculated the direct effect estimate with its standard error. As you can see, this test did not find a significant difference between the direct and indirect evidence. And so the authors concluded that there was no evidence of inconsistency using the node split model. These estimates are on a log scale, so if we convert them to a normal scale, we get the following estimates for the direct and indirect effects. As you can see, the network estimate is more precise, as it has been calculated using information from both the direct and indirect estimates. LNG-IUS is less likely to lead to satisfaction with treatment. Please note that the effect estimate is different in the summary of findings table as it compares REA to LNG-IUS rather than the other way round. We can use models to assess inconsistency in a whole network. That's the global approach. These models take into account the IFs of all the loops in the network. Here is the network again, which shows the comparisons between interventions for the outcome of patient satisfaction. The authors reported that the p-value of the inconsistency model was 0.25, so that they did not find statistically significant inconsistency. Another way of testing global inconsistency is via a design by treatment interaction model. This is a refinement of the inconsistency model approach. Imagine a network comparing interventions A, B, C, and D. That's the top row of the table. There are 10 studies in the network, and there are 7 unique study designs. So by design, we mean the treatments that are compared to each other. So study 1 compares treatments A and B. Study 2 compares treatments A and D, as you can see throughout the rest of this table. So you can also see that there are some multi-arm studies in the network. Those are studies 3, 6, 8, and 9. Here's the network diagram that corresponds to the network in the previous slide. As we've explained before, the nodes are the interventions and the thickness of the lines represents the number of direct comparisons. So, for example, there are 5 direct comparisons between A and D and between A and B, but no direct comparisons for D and E. Here you can see the different unique study designs mapped onto the network. The design by treatment interaction model assesses whether there are differences between studies that have the same design. That is, they compare the same interventions. For example, are there differences between the comparisons of interventions C and D when they are assessed in Design 6 versus Design 7? If there are differences, this means that there is inconsistency in the network. We need then a local approach to find out where that is. Here's another example of testing for inconsistency both locally and globally. This network plot is from a review of immunomodulators and immunosuppressants for progressive multiple sclerosis. This plot shows various different treatments that have been tested in different trials, and the outcome is the number of patients who discontinued treatment due to adverse effects, AE. As you can see, there is only one closed loop in this network, the comparisons between glatiramer acetate, rituximab, and placebo. Here are some snippets from the results of the inconsistency testing. The first result is from a simple test for inconsistency in the glatiramer acetate, rituximab, and placebo loop. This is a loop-specific approach and shows an inconsistency factor of 0.135. As you can see from the p-value of 0.932, this is not significant. This loop-specific approach measures the difference between the direct and indirect evidence in that particular loop. Next, you can see the results from the node-splitting approach. This approach compares the direct evidence with all the indirect evidence in the network. So, for the comparison of placebo with glatiramer acetate interventions 1 and 4, the direct evidence gives a result of 1.37, and the indirect evidence gives a result of 1.50. As before, these are on a log scale. The actual odds ratio of the direct evidence is 3.92. Again, with the node splitting approach, the inconsistency does not appear to be insignificant. P is 0.933. Finally, we can see the results of the global test for inconsistency. The authors have used a design by treatment approach. As you can see, the test for significance here is a simple chi-squared test, and the result is again insignificant. P equals 0.9324. Finally, here's an example of a network meta-analysis in which the authors found some inconsistency. This network plot is from an NMA published in The Lancet in 2018, looking at antidepressant drugs for adults with depression. It relates to the outcome of response to treatment, a dichotomous outcome, and it includes data from all the head-to-head comparisons of the different antidepressants. The authors state that they found 11 loops with inconsistency out of 140 possible loops, and these are shown here. As a reminder, the loop-specific approach assesses inconsistency between the direct and indirect evidence in a particular loop. So if we look at the citalopram fluvoxamine venlafaxine loop, we can see that this loop has an inconsistency factor, or IF, of 1.243 with a p-value of 0.038. Here are the results from the node splitting or side splitting test. As you can see, there is significant inconsistency between direct and indirect evidence for the comparison of citalopram versus venlafaxine. The p-value is 0.042. We will cover assessing the certainty of evidence in Module 3 of the course, but just to note that the authors downgraded the certainty of the evidence for this particular comparison and outcome because of this inconsistency. So, some warnings from the Cochrane Handbook. As always, we need to remember that absence of evidence is not evidence of absence. Please note that the handbook is using the term incoherence, and as I explained out earlier, this is an alternative name for inconsistency. So, how do we handle inconsistency in a network meta-analysis? The first step is always to double-check the data, as incorrect data extraction can result in inconsistency. Then you need to work out where the inconsistency is coming from, examining the loops within the networks to see which are contributing to this inconsistency. You can examine the effect modifiers within the loops to see if the transitivity assumption may have been breached. And you could also conduct sensitivity analyses to test the impact on incoherence or inconsistency if you include or exclude particular studies which may threaten the transitivity assumption. It's worth mentioning a special case when thinking about evaluating inconsistency. Sometimes a network will look like this. It's known as a star network. This often happens when a new class of drugs emerges. In initial trials, the new drugs are only compared to placebo and not to each other. As a result, we have no closed loops in the network, and this means that we can't assess inconsistency statistically. This is because we have no direct evidence to which we can compare the indirect evidence. However, we can still assess transitivity by looking at the effect modifiers in the different trials and making sure that they are similar enough so that indirect comparisons are valid. It's important to understand the difference between heterogeneity and inconsistency, both of which can affect NMAs. Both relate to variability in the data, but are otherwise very different. Heterogeneity relates to variability between effect estimates across studies and can arise from clinical, methodological, or statistical differences between them. It is measured with statistics such as tau squared, Cochrane's Q, and I squared. As explained in the presentation, inconsistency refers to differences between direct and indirect estimates of effect and can arise from clinical and methodological differences between direct and indirect estimates. It is measured locally and globally by tests such as node splitting and design by treatment interaction tests. So finally, here's some further reading and a bibliography for the presentation. Thanks very much.